So we presented our real-world experience of using 177 lutetium PSMA therapy in patients with metastatic castration-resistant prostate cancer. It was a retrospective analysis of patients at UC Irvine at Hoag. In one part, the initial part, we compared the quality metrics and the FDA approval requirements of this new novel treatment that was approved for treatment of patients with metastatic castration-resistant prostate cancer in March 2023. So one of those points were studying the timing of the PSMA scan prior to start of the therapy. We found a variability in real-world practice setting in comparison to the clinical trial environment that was only 4 weeks to be obtained within 4 weeks of start of treatment. And the other point was the variability in terms of reporting the PSMA PET scan in the real-world setting. We found that some of the times the non-PSMA avid lesions were not reported, the liver baseline might not have been mentioned, and we don't know if they are relevant in real-world practice or not. We rather to emphasize the differences between the real-world setting and clinical trial environment. And our recommendation is coming up with an standardized format to report the PSMA PET scan on an individual, in an institution level or a national level to make the outcomes comparable from the real world to trial.
Our patients, when in the real world, had a lot longer of a time span between when they actually got their PSMA PET scan to when they actually got the therapy as compared to what was required within the VISION trial. And I think it highlights the fact that, obviously when you're in a clinical trial, it is a lot more of a controlled setting and there's a lot more checks and balances in terms of how things are done. I believe off the top of my head, it was about 66 days median.
The average time was 66 days, while in the VISION trial was 4 weeks.
4 weeks, so 28 days. So it was definitely a lot longer in terms of what was done in real world compared to the VISION trial. And I think that highlights, obviously, the barriers to actually getting things done in the real world.
So the lack of standardized formats of reporting the PSMA PET scan is the main factor. The definition at the VISION trial of the PSMA avid lesion was radiotracer uptake more than liver. This is not something that is completely agreed on in the field of nuclear medicine specialists. Rather, it is questionable if liver is exactly as important as FDG PET scan in terms of being a baseline. And the other points that we can mention is different practice setting and different barriers to get those scans on time was another reason. The insurance approval might have played a role, and patient and appointments availability in the imaging centers might have played a role, but they are not things that we have studied specifically. These need further investigations.
That's a good question. Actually, 53.6%, especially for our heavily pretreated patient population, we think is actually a pretty good result. The median number of previous treatment lines in our patients was 4 lines of treatment and up to 7. And so these patients had inherently very aggressive disease. And so if you can say that a therapy about 4 or 5 lines of treatment in can give you about a 50% chance of having a PSA 50, I would say that's actually pretty good. Comparing it to the VISION study, which even though it wasn't the primary endpoint, it was about if off the top of my head, about 44% of patients achieved the PSA 50. So pretty consistent with the results in that trial. In our study, the highest reported ones, and again, this is different than what's reported in a clinical trial setting, but from our retrospective analysis, what we were able to see is that the most common ones were fatigue and dry mouth, which is consistent with what was reported in the VISION trial in terms of the most common ones. The frequencies were in our study weren't quite as high as what was reported in VISION, whether that's a bias just strictly from the reporting or given the limitations of a retrospective study. But overall, it seemed like it was a pretty well-tolerated therapy between both our study and the VISION study. I think there's a combination of the standardized format, and then I think what we saw in our study is that it's used a little bit later compared to what was reported in the VISION study. And so finding out which patients are the ones that are more likely to respond and maybe prioritizing treatment for them a little bit earlier on may justify its use in the earlier setting, given the fact that it's restrictive costs and accessibility and level of expertise needed to administer this drug.